everyone. I'm Dr. Mausumi Barthakur from GNRC Hospital, working as a Chief Consultant in Department of Neurophysiology and Epilepsy Monitoring Unit. I'll be talking about epilepsy. Epilepsy is a very old disease, historically almost 5,000 years old. But still today, as of today, it is taken as a very scared. People are really scared to talk about the disease. It is not accepted as any other disease. The reason being its presentation, which is so scary. A person which was absolutely normal suddenly started shaking his hands and legs. He lost his consciousness. He started vomiting, talking irrelevantly, and then after some minutes he is perfectly normal. The presentation made the disease very scary since 5,000 years. Initially, historically, people thought that it is caused by some heavenly deities. So they started worshipping the person. Then after that, they started thinking that it must be caused by some devils, and they started beating up the person. Then finally, Hippocrates in 400 BC, he observed the disease very meticulously, precisely, and he came to a conclusion that this disease is caused by some abnormality in the brain. This particular disease is mentioned in our literature also as Apsamara. In our part of the country, we know it as a Mirgi. There are many people with epilepsy, historically known, lived their life, very successful and victorious life, like Napoleon Bonaparte, Lew Tolstoy, Alfred Nobel, then John T. Rhodes, Richard Barton, and there are so many. They have done excessively well in their different part of their work, and then they lead a victorious and successful life. So looking at them, if you look back into them historically and then see their work, actually those people having epilepsy have really led their life happily and joyfully. Epilepsy, there are many myths about epilepsy or misconception about epilepsy. Like epilepsy is a rare disorder. No, it is around 10 epilepsy per 1,000. Prevalence rate of epilepsy is 10 per 1,000 in India. In our part of the country, the survey which was made by GNRC Hospital way back in 1992, published in a reputed journal in Epilepsy, we found it to be 9.9. Then and that is prevalence, and then incidence of epilepsy varies. In infant it is more, around 50, and then again in young age it goes down, and then elderly people it is increased. There are many varied reasons about that. There are another myth is that it is a mental disorder, which is not. Epilepsy people who are epileptic, they are dull, they are crazy, which is absolutely a misconception as proved by those people I have cited earlier and their successful life. Then those people who is having epilepsy, they should be given some mental, or should allowed to smell some shocks, soothes, all these onion. So these are the practices which are going on, and people think that cures the disease, which is not, precisely not. Then there are another misconception is that epileptic medicines are ineffective. Actually, around 70% of cases, epilepsy treatment is effective. We can control the disease. Regarding a question comes whether epilepsy is curable. We won't say all the epilepsy cases are curable, but yes, if we can classify the epilepsy, which is very important for any physician, then we can at least tell the patient and the attendant about the prognosis of the disease, whether it is curable, whether it will be controlled, and what we have to do about it. Then another thing is that epilepsy has a social prejudice about epileptics getting married. It is thought that epileptic, they cannot get married and have normal life, but which is not true. People with epilepsy can have a normal life. That social stigma attached to epilepsy and marriage is because till 1999, epilepsy was considered at the same line as schizophrenia, and that there was a law, that legal issue about getting married. But in 1999, Indian Epilepsy Society really fought for it, and now people with epilepsy, they can get married, they can have children and live a normal life. Yes, there are some precautions regarding driving epilepsy. With those people who are having active epilepsy, they are not allowed driving license. But other cases, and they have to avoid some, away from the fire, or they should be away from taking swimming and all. But more or less, they can live a very normal life if they take regular medication, and some do's and some do nots they can follow. There are some epilepsy mimics also. There are two main epilepsy mimic. One is PNES, we call it pseudo-seizure also, and another one is syncope. That pseudo-seizure means the person will exactly present like an epileptic, but actually it is not epilepsy. Pseudo-seizure is around 30% in the society, which is not very less. And to differentiate it from epilepsy, true epileptics, we have a very good investigation which is known as video EEG, which I'll come later when I'll be talking about investigations of epilepsy. And then the syncope, we have a definite history about how the person fall and what is the what is his age, any precipitating factor. So many things helps us in deciding whether it's a true epilepsy or not. So these are the myths and mimics about epilepsy. When we come across patients or caregivers with epilepsy, then the question oftenly asked, is it hereditary? Only 4% of cases in particular type of epilepsy can be transmitted. But most of the cases it is not like that. There are some sub-classifications which we come to know, and then we tell the caregiver about that particular disease and how it can, maybe there is a transmission. And another thing which is often asked is whether it is contagious. Epilepsy is not contagious. That is another question. And another thing they ask, will you have to take the medication for lifelong? It is not like that. Sometimes it depends on the type of the epilepsy. There are different types of epilepsy. We divided according to the Epilepsy International League Against Epilepsy classification. We divided as epilepsy syndromes, epilepsy focal and generalized. So when we can classify with the history and the treatment modality, investigative modalities, then we can tell the people and the caregiver about the prognosis. Then another thing which comes in epilepsy is treatment gap. It means uncompliance. Compliance means the person was prescribed an epileptic medicine, but due to many reasons, it may be financial, it may be the fear that epileptic medicine has some side effect, it might cause some defect to the brain, so they don't take it. But what is most important to know is that epilepsy medicines has to be taken very regularly, so that it should be taken as a brain tonic rather than some side effect. It has some minor side effect, but we have to ignore. If we do one tablet, we can calm down our brain cells. If it does not betrays us automatically, then what is the harm of taking it? So that has to be taken care of. And treatment gap is, it was diagnosed, but many people are diagnosed, but treatment has not been taken. So that comes mainly because of the financial issues and also the social taboo. That also has to be taken care of. Sometimes we are asked what are the precautions when suppose we started medicine, then they ask what is the lifestyle difference. Lifestyle, there are not many. Only thing is that they should avoid stress. Stress is a very big factor for precipitating epilepsy, and they should have a regular sleep pattern. It is not the duration of sleep. Suppose we tell them that you should sleep for 8 hours, but it also depends the regularity of the sleep. If somebody goes to sleep say around 10 o'clock, then he has to maintain it. That is another. It is not that you will sleep someday at 10 o'clock for 8 hours, then again someday you will go for 12 o'clock night and then sleep for 8 hours. So that regularity has to be maintained. They should avoid stress. Any other, some people, they do ask us, yoga, meditation, does it help in epilepsy? Answer is anything which releases your stress will definitely help in controlling epilepsy apart from your medication. But only this therapy will not unless you take medication. So that is another important thing. Then what about if I miss one pill in the morning? Can I take both the pills in the evening? The answer is no. You cannot take lunch and dinner together. So it is like that. And then another question they ask: what about their academic life? The answer is as I have already quoted all those famous people, these medicines, neither the medicines nor the disease per se affects in academics. That is another answer to it. Then people, after we clinically diagnose the cases epilepsy, comes what are the investigation of epilepsy. Epilepsy is a clinical diagnosis, but yes, we need some support before starting a very long, I won't say long, at least 2 to 5 years of medication. So the treatment modalities comes like EEG is one, EEG of different variety. It can be a normal awake EEG, a daycare EEG for 1 hour. It can be an extended EEG for 2-3 hours, where we'll accept. We'll feel that person will go for some drowsiness in a quiet room. That environment of the EEG lab itself, the infrastructure, the machinery, everything counts. The technician, mainly the technician. So everything counts to get a result. They say that in a normal awake case, it is 50% positive sensitivity is present. It means out of 150 will give you the positivity. Then we have another modality of overnight EEG. That is that the person will stay for the night, he will go for 2-3 cycles of sleep, and we expect that around 80% positivity comes. Then there are another modality where patient is kept for long, 3-4 days, and we like to capture some of events. As I have described earlier about the pseudo-seizure or paroxysmal non-epileptic attack disorder, we call it PNES. This is a golden investigation to differentiate between those pseudo-seizures and seizures. We capture the seizure, whatever event, or we won't call it seizure, we'll say the habitual events will be captured one side, and another side the brain activity which is coming up, which will be displayed in the EEG, will be analyzed together, and finally we'll come to a conclusion: this person is having seizure, having epilepsy or not. So as I have told you already, it is about 30%, it is not very less. So 30% people which presents with pseudo seizure, that differentiating it gives a relief and smile to the caregivers most of the time. So video EEG is to differentiate this. When we are talking about EEG, I am just talking about video EEG. Nowadays EEG is connected to the video, where video shows the patient his activity and EEG gives the activity inside the brain. So that is the big advantage of this video EEG recording. Nowadays stereo EEG has come up. Stereo EEG, the utility of stereo EEG is mostly pre-surgical. Suppose they will implant some EEG leads inside the brain and try to find out where from the epileptogenic zone has come, and stereotactically it will be implanted, and that is mostly interest to the neurosurgeons who wants to find out in some cases which is that scalp EEG is not supporting them, so they go for stereo EEG. That is EEG. MRI, another very important tool for epilepsy diagnosis. MRI will give a picture of the person's brain, whether it has got some anomalies. Mostly we have seen because of the low care of the infant and maternal care just before the birth of the baby, during that 9 months period. What happens? We get babies where there is defect and the MRI shows it. When it comes in that point, like on MRI positive epilepsy, there is a chance of having refractoriness. It means one medicine may not be able to control. So MRI is a very important tool. Then we have tools like Deptt, positron emission tomography, which shows the metabolism of the brain. When they are MRI negative people, we go for Deptt. SPACT is another modality in a very good center. Then we have fMRI, that's functional MRI, which shows the language area. And then we have MAG, or magneto-electroencephalography. MAG is not only in 2 centers of India it is available, but others, video EEG, MRI with epilepsy protocol, PAT, this has come up, this has already reached Northeast, and I am very happy to say GNRC Hospital has started video EEG way back in 2011. We have the most highly technical, like with 4 units, it's a big unit we have, and in the private setup it is the biggest unit. We have done almost more than 10,000 patients with epilepsy, and it gives a good support to the clinician to treat the person. with confidence. That is another. And these are the list of investigations. So we have an epilepsy, the modality of investigation differs along with the type of epilepsy actually. If we are dealing with a syndromic epilepsy, we have signature EEG. So one night EEG, if we get positivity, that will be enough. Suppose it is not, we excluded the syndrome, we are talking about some refractory. So when I talk about refractory epilepsy, it is about some epilepsy which is not responding to treatment. Refractoriness again depends on many causes, so that will be, there are many causes, one of them is MRI positive. So those cases we may think about surgery. Before going to that, we have to talk about the treatment of epilepsy properly. So treatment of epilepsy will be classified into medical. Medical means we will be treating with medicine. It may be polytherapy, it may be monotherapy to start with, it can go to polytherapy. Then there are almost 70% cases are controlled with medicine. This is very, it's a good thing that people get well controlled. Then comes those who are not controlled, which are refractory. Usually we get refractoriness, we call it refractory epilepsy. We get refractoriness because of some reason, maybe as I told you earlier, MRI positivity, there may be some family history also, maybe some reason that it has relapsed earlier. Anyway, there may be many reasons. So then comes the next line of treatment, that is the surgical option of epilepsy. Earlier, surgical option of epilepsy used to come only after a long period of medical treatment, but things has changed. Now when the person with epilepsy, PWE, when it's not controlled within 2 years, we have to refer the person for surgery. Surgery is a modality which almostly used. There are many centers in India where epilepsy surgery has been done, and it has come up in recent last 3-4 years. There are many centers has opened up. I'm happy to inform that GNRC Hospital had done successful 2 surgeries of 2 epilepsy candidates way back in 2015, 25th March, and both of those patients, those 2 candidates are doing very well. They are living a very happy life, and that is the option. But before going to the surgery, there should be profound pre-surgical evaluation. There should be a team of neurologists, neuroradiologists, neurophysiologists, neuropsychiatrists. Everybody, there should be a video EEG unit, which is the core of epilepsy comprehensive epilepsy monitoring unit, and there we'll try to find out which area from the brain, the epileptogenic zone, from where it's firing, epilepsy is coming out, which is refractory, which is not responding to so many treatment. So then we'll find out that surgeon has to do their job by cutting out that particular area. So this is in a very simple way, that is epilepsy surgery. And then there are another modality, some candidate which does not suit for surgery, they have to go for vagal nerve stimulation. And this is another modality of treatment. And some people, they ask us if there is a role of diet in epilepsy. There is a ketogenic diet which is not very easy to follow, but still there is an option, especially in case of children. There is an option for ketogenic diet. That is another modality of surgery. So we call it surgery can be taken up in many ways. Mostly temporal surgery is done most frequently. So these are the treatment options of epilepsy. But the only thing is that knowing the disease and the caregivers giving them the appropriate information how to accept the disease, that is the primary responsibility of the physician, and then accepting it and sticking to the physician word is the responsibility of the patient. Knowing the disease, how to go hand in hand, conquering the devilish force, whatever way it was described earlier, either with medicine or with surgery, but trying to have a normal life in spite of having the disease in a very positive way is the key factor of epilepsy management. You have to see your doctors regularly, at least 6 months. If you are all right, okay, you don't have to come. But thing is that if you have sometimes what happens, there are some small attacks. Epilepsy is not just shaking both hand and leg. As I told you, it may be as trivial as like smacking. It may be as trivial as coughing. It may be as trivial as just get absent, being absent for some time. So these are small attacks which sometimes get unnoticed by the caregivers. So they will not come to the physician. They will not even come for checkup. So that is another way they finally present it a bigger seizure. So those things, they have to be very alert. Both the patient and the caregiver has to be very alert about the disease. First they have to accept it as a disease like any other disease, like hypertension or diabetes, and then they have to follow the physician's advice, whatever they tell, take the medication regularly, religiously, and then hand in hand they should have a very normal and positive life. Maybe even if it's a surgical remedy, okay, he has to go for the surgery, and if it's a medical remedy, he has to take the medical remedy. But the only thing is that we should not get scared by the word epilepsy. We have to fight against it. We have to win it, and finally that winning with the disease is should be our aim. Thank you.